Good evening, everyone. I am Prashant Agrawal. On the behalf of Adley Oncology, I would like to welcome Dr. M.B. Agrawal, sir, our guest speaker, Dr. Rayan, our moderator, Dr. Amit Khurana, and all our eminent discussants and participants. With your permission, I would like to brief about the Adley Oncology. Adley Oncology cherished 35 years of excellence that is dedicated to oncology. To bring expensive care, our promise is to bring expensive cancer treatment within the reach of every patient, because we believe every moment of life is precious for cancer patients. We are continuously working on new drug delivery systems and the new NDDS formulations. Recently, we have launched Magistrol acetate oral suspension, and we are going to launch imatinib oral solution and methotrexate suspension. So all these things helps to increase the patient compliance, better safety and efficacy. We are going to launch 15 NDDS formulations in next 2 years of time. Although we are having the high range of hematology products, but recently we have launched acalabrutinib, carfilzomib, nilotinib, and eltrembo PEG. At the end, I would like to emphasize that Beta Drugs Limited earns the prestigious spot on the Forbes. This recognition is the testament to the company's sustainable growth, strategic vision, financial strength, operational efficacy, and commitment to excellence. Now, thank you all of you for listening. And now I hand over the session to Dr. Amit Khurana, sir.
Thank you, Mr. Prashant Agrawal. Let me share the screen. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Ryan D. Casade from Fred Hutchinson Cancer Center, Seattle, USA. And he is going to lecture us on CAR T-cell therapy for adult ALL. Where are we in 2024? This webinar is brought to by Mumbai Hematology Group, supported by Adley Oncology and managed by Perfect Square. I thank Mr. Ashutosh Shukla and team from Adley, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Ryan D. Casade from Seattle, Washington, USA, all our discussants who are themselves very eminent hematologists and medical oncologists, and you participants for spending your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 21st of April 2024, from 11:30 a.m. Indian Standard Time onwards and 7 a.m. UK time, we have Dr. Shankara Panisha from Birmingham, UK, speaking to us on treatment landscape of CLL in 2024. Let me introduce our discussions for the day and here displayed in alphabetical order. To start with, we have Dr. Aditi Shah Kaskar from HCG Hospital, Borivali, Dr. Balkrishna Parte from Nanavati Max Super Specialty Hospital, Vilepale, Mumbai, Dr. Chirag Shah from Apollo Hospitals, Ahmedabad, Dr. Darshana Rane from Wockhardt Hospital and Reja Hospital, Mumbai, Dr. Hamza Dalal from Fortis Hospital, Mumbai, Dr. Hari Menon from St. John's Medical College Hospital, Bengaluru, Dr. Kirti Hegde from NHSRCC Children's Hospital, Mumbai, Dr. Mohammad Rizwan Sheikh from Seth GSMC and KEIM Hospital, Mumbai, Dr. Parth Ganatra from Bhai Jarbai Wadia Hospital for Children, Parel, Mumbai, Professor Dr. Colonel Prakash Chitalkar from Sri Aurobindo Institute of Medical Sciences, Indore, Dr. Prashad Hiwarkar from Bhai Jarbai Wadia Hospital for Children, Parel, Mumbai, Dr. Preeti Mehta from SRCC Children's Hospital, Mumbai, Dr. Punit Jain from Apollo Hospitals, Navi Mumbai, Dr. Santanu Sen from Kokilaben Dhirubhai Ambani Hospital, Mumbai, Dr. Sharad Damodar from Mazumdar Show Medical Center, Narayan Health City, Bengaluru, Dr. Suprakash Sanyal from Fortis Hospital, Mumbai, Dr. Sumit Med from Tata Memorial Center, Attract, Mumbai, Dr. Vikas Talreja from Regency Hospital, Kanpur. Now it's a time to introduce our guest speaker for the day. We are with us, Dr. Ryan D. Casade from Fred Hutchinson Cancer Center, Seattle, USA. Dr. Ryan D. Casade is Associate Professor at Division of Hematology and Oncology, University of Washington School of Medicine, and Associate Professor at Clinical Research Division, Fred Hutchinson Cancer Center, Seattle, Washington, USA. He completed his undergraduate and medical training at the University of Wisconsin in Madison. In 2010, he started Hematology Oncology Fellowship at the University of Washington and Fred Hutchinson Cancer Research Center. He then joined the faculty at this institution in 2014 with a focus on acute lymphoblastic leukemia in adults. Since then, he has led several investigator-initiated and industry-sponsored clinical trials of various strategies for this disease, including novel agents and cellular therapies. He has a particular interest in developing novel chemotherapy strategies for high-risk populations, including older adults and those with relapsed refractory disease. He has served on the NCCN Guidelines Panel for Acute Lymphoblastic Leukemia and the Leukemia Working Group of the Southwest Oncology Group. Today, he's with us and he's going to lecture us on CAR T-cell therapy for adult ALL. Where are we in 2024? Well, thank you so much. Over to you, Professor Dr. Ryan Casade.
Thank you very much for the invitation. It's a real pleasure to be here. I'll go ahead and get my slides started. So again, it's my pleasure to discuss the role of CAR T-cell therapy for adults in B-cell ALL. The objectives of my talk today will be to summarize the current options for adults with B-cell ALL, provide an overview of the various immunotherapy agents for B-cell ALL, talk about some of the practical challenges that exist in delivering this treatment to adults with ALL, and then highlight some new strategies and approaches that are under development. So I think to understand where CAR T cells have sort of evolved and established themselves in the treatment of this disease, it's important to understand the broader landscape. So I'll do that first by talking a bit about newly diagnosed B-cell ALL, at least how we treat it in the USA, recognizing that even in my country, the options for treatment will vary by physician comfort and cost, because this is such a rare disease. Not a lot of physicians are familiar with the nuances and some of the varied ways that exist to treat it. So for Philadelphia chromosome negative B-cell ALL, I think most would agree that young adults are optimally treated with asparaginase containing regimens modeled after pediatric approaches. So the so-called C10403 regimen, which is modeled after a Children's Oncology Group regimen. There's also the E1910 study, which I'll talk about a little bit later, that includes asparaginase for younger adults. Hyper-CVAD, though, remains a commonly used and certainly acceptable option in this patient population. For older adults, though, there's really no clear standard of care. This is generally defined as adults over the age of 60. For fit patients that have good resources and good support, an intense approach like Hyper-CVAD or mini Hyper-CVD with inotuzumab ozogamicin can be used. But for those that are not medically fit or those that lack good social support or resources, it becomes a lot more challenging. Some will use Hyper-CVAD with some dose reductions. One approach we've studied at my center is the dose-adjusted EPOCH regimen, historically used for lymphoma. For people in middle age, which includes myself, it's really any of the above options sort of tailored to the specific situation. For Philadelphia chromosome positive ALL, the historical approach that most would use would include Hyper-CVAD with a tyrosine kinase inhibitor, generally with allogeneic transplant at first remission, but that is now being called into question somewhat with the use of measurable residual disease. There's also low intensity strategies that use the efficacy of the TKI and thus eliminate a lot of the chemotherapy. But blinatumomab has really started to take a foothold here, either as a consolidation approach after an induction that includes dasatinib and prednisone, as was studied in an Italian study and then subsequently in a US trial. And then most recently, a combination of ponatinib and blinatumomab has been studied by the group at MD Anderson. So this is sort of the general landscape, I would say, of treating newly diagnosed B-cell ALL, at least in the US, and I imagine a lot of other jurisdictions as well. A tool that we use a lot in ALL, and I would argue it has the strongest role in clinical practice in ALL, is measurable residual disease, or MRD, which can be very helpful at identifying patients at highest risk of relapse if you continue to treat them with chemotherapy alone, and thus potentially argue change in treatment if that's identified. There are lots of data out there that support the use of this tool. This is just a study from our center from a few years ago looking at the role of MRD negativity in the context of hyper-CVAD, which essentially shows that most patients are going to become MRD negative within the first 3 to 4 months of treatment, but the earlier you achieve that depth of remission, the better your outcome is. Now, I touched on blinatumomab before. So blinatumomab is a bispecific T-cell engager. It was the first bispecific agent of any kind approved for any indication. This is just a cartoon showing how it works by targeting the CD3 on effector T cells and CD19 on the leukemic blasts. It's important to remember this is a somewhat difficult drug to administer. It's given as a 24-hour continuous IV infusion for 4 straight weeks, and then there's a 2-week break. It has a unique side effect profile because of the way it works, cytokine release syndrome and neurologic toxicities. And then, interestingly, the response rate and toxicity seen with this drug is proportional to the disease burden. So the higher the disease burden, the lower the chance the drug is going to work, but the greater the chance is that it's going to induce toxicity. So the reason I bring this up now is because really one of the first places blinatumomab was studied, and then it was subsequently FDA approved uniquely in this setting, is for the treatment of chemotherapy refractory MRD. So this is really the place where it has the highest activity and lowest rates of toxicity. So about 80% of patients who get blinatumomab for MRD are able to have clearance of that MRD, achieve a complete MRD response. CRS and neurologic toxicity are fairly uncommon when you treat patients in this setting. And very interestingly, for the subgroup of patients that were treated on this large prospective study in Germany, who had a good response to blinatumomab and then did not undergo a subsequent allogeneic transplantation, about 30% of those patients are still alive in remission a median of 5 years later, suggesting that some of the patients who respond to this drug can actually derive durable benefit. Now, the challenge is we don't really know how to identify those patients, but the fact that you can have that proportion of patients live that long without relapse in a setting where historically virtually everyone will relapse if all they get is chemotherapy is really quite astounding. Now, taking a step further, blinatumomab has now been studied in the frontline setting in a randomized fashion. That study I showed before is specifically a single-arm trial, but this was a randomized trial that took patients that were aged 30 to 70 and gave them all an induction and intensification combination of chemotherapy that was modeled after a historical trial, the E2993 trial. But notably, rituximab was added for those that were CD20 positive. That was not an option when that original study was done. And then patients were randomized to, if they achieved a complete remission, to one of 2 arms. So the control arm was to continue on with the traditional consolidation chemotherapy. The investigational arm, however, included 4 cycles of blinatumomab along with those 4 cycles of chemotherapy in a somewhat alternating schedule. After the approval of blinatumomab for patients that had persistent MRD, though, this study was modified. So the only patients that got randomized were those that achieved an MRD negative remission. So at that point, once that drug became widely available, it was thought unethical to not offer that drug specifically. So patients that got into an MRD positive remission were assigned to get blinatumomab. Those that were MRD negative were randomized between these 2 different arms. And these were the survival curves that were presented at ASH 2022 as part of the late-breaking abstract session. It's a little bit hard to appreciate the details of this. It's just the quality of the figure that's available. But the black line is the blinatumomab plus chemo arm. So that's the investigational arm. You can see the survival is significantly better. This trial was actually stopped early because of the strong benefit that was observed. Now, some subgroup analyses have been done in this trial to try to understand a bit more about which patients may benefit the least or the most with this approach. And one interesting one was they looked at the subgroup of patients that had MRD that was less than 0.01%, which was the protocol defined cutoff, but it was still technically detectable, so sort of an equivocal result. And they looked at that subgroup of patients and compared it to those that were unequivocally MRD negative. And interestingly, the patients that had that equivocal MRD less than 0.01% level, their overall survival benefit with blinatumomab was more pronounced. Their hazard ratio was lower. But because that was a small subgroup with relatively small numbers, that difference was not statistically significant. The benefit was still statistically significant for those that were unequivocally MRD negative. The hazard ratio just wasn't quite as low, suggesting that the difference wasn't quite as pronounced. The other subgroup that was looked at was breaking it down by age, with 55 being the cutoff. Here, the benefit was most pronounced among younger patients. So you see the hazard ratio is only 0.18, and the statistical significance was very strong for this subgroup. In fact, there was no statistical significance for the older adults, those over 55. So the authors concluded in their abstract from this subgroup analysis that the benefit of adding blinatumomab in the frontline setting seems most evident for those that are younger and those that are in MRD negative remission based on those statistical comparisons. My take is actually a little bit different. We know historically that having persistent MRD is associated with a bad outcome if you continue with chemotherapy alone. And if we had better, more reliable MRD testing, we'd probably be able to identify more of those patients in this equivocal less than 0.01% subgroup. And those are probably the patients that actually get the most benefit out of blinatumomab by changing their treatment. As I mentioned, the benefit was more apparent. It just wasn't statistically significant because of the small numbers. So reportedly, samples for more sophisticated MRD testing have been banked as part of this trial. Those data are not yet available. We don't know how it'll shake out, but a lot of us in the field are eagerly looking forward to seeing what comes of these analyses. So as the role of blinatumomab expands in the frontline treatment of B-cell ALL, this will hopefully translate into fewer relapses. But what we don't really know yet is what is that going to mean for those who do relapse? Is this just going to select for more resistant disease, making the salvage strategies we have less effective? Are we going to start to see more CD19 negative relapses? We know that this is a potential consequence of using CD19 directed therapies. If those therapies fail, it might be because the disease downregulates or stops expressing CD19. And then the role of transplant actually may become less clear. And there's sort of two different ways to think about this. So if we can show that the outcomes are better if you don't do a transplant up front because of our improved non-transplant therapies, we'll be doing fewer transplants. However, for these patients that have persistent disease that can't get into a deep enough remission to offer a transplant, if we can get them into a deeper remission with things like blinatumomab, we may actually be doing more transplants up front. And really, I think more specific analyses from the BLAST trial with blinatumomab, the E1910 randomized trial that I mentioned, and others will hopefully clarify this. They may not be statistically powered to answer the questions definitively, but it'll hopefully give us more clues as to how to use these different approaches. So that was a pretty deep dive into the frontline treatment of ALL, which really wasn't the focus of this talk. It was really just to set the stage to understand how we are now using the options that we have for relapsed refractory B-cell ALL, because obviously one cannot have relapsed or refractory disease without having gone through some sort of frontline therapy. So blinatumomab really was first approved in the relapsed refractory space on the basis of two different prospective trials. There was a randomized trial for Ph negative disease, the Tower study on the left. There was a single arm trial in Italy, the Alcantara study. So blinatumomab is approved in this setting. But as I mentioned before, disease burden is correlated to response with this drug. So these are forest plots from two different trials, single arm trials where everybody got blinatumomab, and you can see both for Ph negative and Ph positive disease on the top and bottom respectively, that those that had a low disease burden, so a low burden of bone marrow blasts on the top of those two curves, their response rates were much higher farther to the right on the x-axis. Whereas those that had a higher disease burden, the depicted on the bottom of these two figures, the response rates were a lot lower, only 20 or 30%. The second option for relapsed refractory disease is inotuzumab ozogamicin, the CD22 antibody drug conjugate. This got approved based on a randomized trial done several years ago. Just as a reminder, this drug, unlike blinatumomab, is much easier to administer. It's given as a 1-hour IV infusion on days 1, 8, and 15. Cycle length is generally 3 to 4 weeks, depending on which cycle you're in. Side effects of this drug, the most important one to remember is sinusoidal obstructive syndrome or veno-occlusive disease. While a devastating complication when it occurs, it's fortunately relatively uncommon, though other forms of hepatic injury can definitely be seen, usually just biochemical changes in the liver tests. And then you can see cytopenias as well. They tend to not be as severe or prolonged as traditional chemotherapy, but it definitely is still a possibility. A newer way to use inotuzumab is to combine it with other agents, and perhaps the most provocative or admittedly complicated way that this has been done is by combining it with the mini hyper CVD chemotherapy regimen, which is a dose-reduced version of the traditional hyper CVAD combination. So this is combined with mini hyper CVD with or without blinatumomab. And this was pioneered at MD Anderson initially for patients with relapsed refractory disease. And it's the name of this regimen has changed a little bit over time, in part because they had to modify the regimen because of some toxicity concerns. So the mini hyper CVD component is limited to only 4 courses. So there's sort of 2 A parts and 2 B parts. They've modified the inotuzumab now to be both fractionated and reduced. So instead of giving 1 big dose per cycle, they give 2 smaller doses split over the course of about a week, and then reduce the dose as you get deeper into the treatment. So the total cumulative dose is less. And then that's followed by 4 courses of blinatumomab. And then patients could go on to receive alternating cycles of POMP for 3 months, followed by a cycle of blinatumomab, and then do that 3 times for a total of a year. But because this is a study of relapsed refractory disease, a lot of these patients did go on to stem cell transplantation. Importantly, they still saw SOS with this approach, but after they modified it to have this fractionated and reduced doses of inotuzumab and so forth, their rate of SOS was only 2%. And then here are the survival curves that were included in this publication, the long-term follow-up. The distinction here, the blue line is what they call the post-amendment. So again, this was where they reduced the cycles and gave the alternating schedule of inotuzumab. The original description of the regimen was the pre-amendment, or the red line. So this is not a randomized comparison. All of these patients got mini hyper CVD plus inotuzumab, but in different approaches. But you can kind of get a sense that with modifying the strategy, the outcomes got a bit better. But this is a relatively complicated approach, lots of moving parts. Still, the survival, while this is a very high-risk patient population, the median survival looks like it's around 2 to 3 years or so, with a lot of these patients dying relatively early, presumably due to their refractory leukemia. A more recent strategy that we've looked at my center is a more intense chemotherapy backbone that is hopefully going to be more effective and a simpler mode of administration for the other components. So this is a combination of EPOC and inotuzumab. And you can see the schema of the regimen depicted there, where the inotuzumab is given separate from the chemotherapy on days 8 and 15, and then the cycle is repeated every 4 weeks. We were able to give doses of inotuzumab up to 0.6 milligrams per meter squared on days 8 and 15, so 1.2 milligrams per meter squared per cycle, which is about a third of what the traditional FDA-approved dosing is when you're giving it as a single agent. There were no new safety signals identified with this approach. We saw 1 patient develop SOS, and it was someone who had that complication after a post-study myeloablative transplant, a situation where unfortunately we see that complication sometimes independent of inotuzumab. And the overall complete response rate was 83%, and 70% were MRD negative by flow. Importantly, 5 out of 6 with extramedullary disease were able to respond, a situation where we don't have as much good evidence in terms of activity. And importantly, every patient that we screened and enrolled were ultimately evaluable. So the intent to treat CR rate was still 83%. We didn't have any attrition on this trial, suggesting that this is a relatively reliable, accessible regimen that doesn't have a lot of sort of drop off while it's being administered, either because of complexity or toxicity or whatever. But an important limitation of inotuzumab is again, the hepatotoxicity that you can see, and SOS is definitely the most feared version of this. There have been studies to look at risk factors for this. Probably the two most significant are either receiving a dual alkylator-based conditioning regimen for a subsequent hematopoietic cell transplant. So for patients that get inotuzumab and then go on to transplant, it would appear that getting a dual alkylator-based conditioning regimen like busulfan and cyclophosphamide significantly increases the risk of developing SOS. Also having pre-existing liver disease, whether that's an elevated bilirubin or elevated transaminases, seems to be associated with greater risk as well. Now, finally getting to CAR T cells. So there are now 2 available products for adults with B-cell ALL. There's the Tysogen laclusil and brexacathogene autolusil. I'll talk a bit about each of these and sort of how they fit together. How we deliver these products requires a lot of infrastructure because of their complexity. So I thought it might be useful to talk a little bit about how we do that at our center. There isn't a right or wrong way of doing it. This is just how we do it. And it evolved out of our bone marrow transplant program. So a lot of the setup, idiosyncrasies, and so forth that we have for our transplant program still exist in our cell therapy program as well. So we have an intake office that's staffed by nurse practitioners and physician's assistants that help bring patients in. So patients get referred from all over the place. We have these medical professionals who gather information about the patient, talk to the patient, the referring provider, and so forth to sort of get them in the door. We have a dedicated outpatient clinical service that specifically focuses on taking care of these patients and that are receiving CAR T cells as well as other cell therapies. It's staffed by providers with an interest and focus on these treatments. So again, a lot of the staff actually came from our BMT program, sort of spun out of our transplant program. The attending physicians have a range of experiences. There are folks like me who come at it more from a disease focus, where maybe their background interest is more in lymphoma or leukemia, but we also have physicians that really come at this from more of a modality perspective, where they're historically part of our transplant group, but have an interest in cell therapy more broadly. When these patients get hospitalized, they're managed on our inpatient BMT service. And when they experience complex toxicity, there's often very close collaboration between our inpatient BMT team as well as the outpatient cell therapy specialists to try to help work through whatever toxicities the patients are experiencing. So this is the setup we have currently that we use to deliver these products to patients who are getting CAR T cell therapy. So now getting back to the data. So this is the study of Tysogen laclusil, the first CAR T cell product approved for any indication. This was approved for young adults and children with relapsed refractory B-cell ALL. Unlike the EPOC inotuzumab study I mentioned before, where there was 0 attrition, these trials unfortunately have quite a bit because of the complexity of screening patients, getting their cells collected and manufactured and so forth. So a pretty sizable subgroup of people were not able to complete this trial. And again, this is a trial of mostly young people. Median age was 11, but very heavily pretreated. Very high response rates, 81% for those in the per protocol subgroup. When you consider it by intent to treat, it drops to 66%. But all of these responses were MRD negative, so very potent. And there was a lot of toxicity. 3/4 of patients developed CRS. Half of the patients had to go to the ICU. 13% had grade 3 neurologic events. There were 19 deaths for patients on this trial. Only 4 were not due to relapse, so presumably due to complications. And then here are the survival curves from this original publication showing, about 50% long-term event-free survival, at least beyond a year in this disease that, historically has a relatively poor prognosis, even in children. So very encouraging preliminary, initial data from this first product. The second product to become available is brexacaptogene autoleucel for adults. This was studied again in relapsed refractory B-cell ALL on the phase 2 ZUMA-3 trial. Similar story where there was a relatively high rate of attrition. About a quarter of patients were lost in the course of screening and getting their cells manufactured. But among those who were treated, 71% were able to get into remission, and virtually all of them were MRD negative. The median duration of remission was about a year at the time of this original report. And only 18% of these patients underwent a consolidative transplant. So these relatively long remissions are in large part because of the CAR T-cell therapy. Not a lot of these patients got subsequent treatment after their CAR T-cell therapy. In terms of toxicity events, about a quarter of patients developed significant CRS, similar rate of patients getting severe neurologic events. Only 4% had treatment-related death. And it's important to remember, in the 3 or 4 years since the Eliana study, the Tysogen Lehusel study was done, we've learned a lot about managing and preventing some of these toxicities. So some of that reduced rates of toxicity is not necessarily because the CAR T cells are safer, but just we're getting better at managing these complications. They're defined a bit differently and so forth. So the rules changed a little bit. Here is the key survival curve from this paper. This can be a little bit confusing, but the black line are all the treated patients. The purple or lavender line on the top are the patients that got into complete remission. So you can see those who responded had a much better outcome than those that didn't, which are the red curve. Now, more recently, there's been an effort to describe results with Brexacel in the post-marketing setting. And this was a large collaborative effort across the US, some 30 different centers, many of which are affiliated with academic institutions, but also large private community-based facilities as well that can give CAR T-cell therapy, where we were able to collect outcomes from almost 200 patients that received Brexacel. And this is the so-called real-world collaborative of CAR T-cells in adult ALL, or ROCA analysis. On the left, you can see that response rates were comparable to what was reported in ZUMA-3 with about 90% CR rate and 80% MRD negative among those responding. The toxicity rates on the right, 80% of patients had some form of CRS. Fortunately, only 11% was grade 3 or higher. ICANS, though, the neurologic toxicity remains a challenge. About half of patients get some form of ICANS, and 31% were grade 3 or 4. So relatively high rates of significant neurologic toxicity with this product. When looking at the long-term progression-free survival after Brexacel, if you break the patients down by their response to this product, so MRD negative responses on the left and MRD positive responses on the right, and then look at what was given after CAR T-cell therapy in a landmark analysis, you can see that patients who received some additional consolidation or maintenance, that's what the C/M stands for, seemingly had a much better outcome. That includes the patients that had a really deep response. Now, the consolidation therapy here was largely allogeneic transplant. The maintenance therapy was largely TKIs for those with Ph positive disease. It wasn't exclusively those interventions, but that was primarily what it was. So this suggests that even those who have a good response to Brexacel, giving some additional treatment thereafter, if you can, may improve the chances the patients will stay in remission. Now, that is in contrast to some other studies that have looked at the role of transplant after CAR T cells, where it's often viewed as a fairly controversial topic. So, for example, there's data from the Memorial Sloan Kettering group showing really no benefit to using transplant after CAR T cells for adults with ALL. But then there was a later study from a group in China that seemed to suggest very strongly that those that got CAR T cells and then used that as a bridge to an allo transplant, the red curve on the right, seemingly had a strikingly better leukemia-free survival. So the data out there are a bit disparate on this topic. It's obviously a very challenging situation, and only very selected patients are able to get through such a complex treatment of getting CAR T cells and then getting a transplant. So it's a topic that is still a little bit unclear. Now, if you look a little bit closer at the toxicity data with Brexucel, just to have a better working understanding of what this product has the potential of doing. So the time to onset of these toxicities, the CRS and neurologic toxicity, is interestingly a little bit later than what has been reported with other products for other diseases. So the median time for CRS was about 5 days, and it was about 9 days for the ICANS. The duration is about a week. So when patients get these complications, they can last for multiple days. In terms of sort of more practical intervention needed in the ZUMA-3 trial, some 80% of patients got tocilizumab. 3/4 of patients were given corticosteroids. Nearly half of patients received vasopressors, presumably as part of managing hypotension and shock from CRS. And as I mentioned before, there were 4% treatment-related deaths, and there were 2 patients who suffered that. So one was septic shock, and the other was brain herniation as a manifestation of severe ICANS. Now, we've also looked at the toxicity in the context of this ROCA collaborative group. So again, this is sort of the real-world delivery of Brexucel, looking at the toxicity in a seemingly less selected patient population outside of the context of a clinical trial. So this included about 152 patients of that original cohort that had sufficient data to report their toxicities. About half of the patients had greater than 5% bone marrow blasts. So interestingly, quite a few of these patients who were treated had a relatively low disease burden. Some key observations from this report. Again, the time to onset of these different toxicities was pretty similar to what was reported in the original ZUMA-3 study, where the median time was a bit later than what you might otherwise have predicted. And interestingly, if there was no incidence of ICANS within the first 3 weeks, there was really no realistic chance of any new neurologic event. So one of the precautions we tell patients historically is that, oh, you're not supposed to drive or use heavy equipment for like 2 months after getting CAR T-cell therapy. Well, it turns out there's really no evidence to support that, at least not with Brexucel, sort of a historical restriction that was put in place before we knew much about what these toxicities did. We then did a Cox regression analysis to try to look for predictors of longer term outcome. And interestingly, even though early death from CRS was quite rare, if you experienced grade 3 or higher CRS, you had a greater than 2-fold chance of dying for some reason. We don't know exactly why. We're looking into this, whether it's late onset infections or maybe some relapses probably, but it's for overall survival, not event-free survival. So presumably these are mostly non-relapse mortality events. So again, we're still trying to figure this out, but it suggests that maybe these early toxicity events may actually be related with longer term complications as well. If this topic is of interest, this group has been quite productive. It had multiple abstracts presented at last year's ASH meeting, some for oral presentations, some as posters, and I've sort of just summarized them here. So knowing that we have these 2 products, Tisocel and Brexucel, there is this overlap in age where they can be used for young adults because of how they were studied. So how does one choose between these 2 options if they are both available? So it would be inappropriate to claim that one is superior over the other. They've only been studied in single-arm trials. No one has done any kind of comparison, not even a retrospective comparison. So I'm certainly not here to say that one is better than another. As I mentioned before, the way we manage CRS and ICANS has evolved in the time that these trials were done. So you have to remember that when looking at the toxicity data and how the different events were defined, because the definitions have been a bit different between the trials. As I said, we've gotten better at managing these things. So high toxicity rates in Eliana don't necessarily mean the same as when you look at the numbers from ZUMA-3. But there are specific features of each product that might make the decision for you in a sense. So again, if you look at the approved indications, at least in the US prescribing information, Tisocel has this fairly distinct description for approval of patients with refractory disease or those in second or later relapse. whereas the approval language for Brexucel is a more generic relapsed or refractory. So what that means from a practical perspective, if you have a patient who is in first untested relapse, Tisocel is technically not approved in that setting. So if you really wanted to give CAR T cells, you may be limited to Brexucel. There's the different age ranges that were studied. So Tisocel was studied in patients up to 24 years of age. So that meant basically anybody before their 26th birthday, whereas Brexucel was age 18 and up. So if you have somebody who's 26 or 27, Brexucel would actually fit those criteria, but not for Tisocel. There may be familiarity with the different manufacturers where you just have a bit more of experience working with the companies that produce the products, where you feel more comfortable with one or the other. And importantly, Tisocel can actually be given more readily as an outpatient. So if there's resource constraints or a patient really doesn't want to be hospitalized for some reason or whatever, Tisocel at least has that ability to more readily be given as an outpatient. But a really important limitation for all these products is access. So these are only available at certain centers. FACT accreditation is generally a requirement for being able to give CAR T cell therapy, just to give you some perspective on what is necessary. There's a limited bandwidth for cell collection and manufacturing. So this isn't an infinite resource. There's only so many leukapheresis machines, for example, at a particular center. A lot of big, referral hospitals are going to have critical care doctors, neurologists, and so forth, on site. But it's important that those subspecialists have expertise in managing these different complications, so that they know kind of what to expect, what the usual natural history is, subtle differences in presentation, and so forth. And again, these are really expensive products, which can be, they can price some places out just based on their cost alone. But there's lots of ongoing effort to try to address these complex challenges. So they are currently limitations now, but in the future, some of these may be less of a problem. I included this slide not because I plan to go through it in detail, but it just sort of highlights ways to manage CAR T associated CRS and ICANS. The package insert for Brexucel is what is largely depicted on the right, and how that differs from what our institutional practice is. But you can see that for CRS, we generally use Toci and dexamethasone, reserving alternative anti-cytokine therapies and high-dose steroids for those with more severe manifestations. ICANS, we generally rely on corticosteroids. It's not clear that anti-cytokine therapies have a clear role for neurologic toxicity. What about prophylactic intervention? Can we do something to prevent these toxicities from occurring? So there are some data on this topic, but not really specifically to adult ALL. We use anti-epileptic medication pretty frequently, particularly for patients that are thought to be at high risk of ICANS. Drugs like levetiracetam are generally well tolerated. There is no clear role yet for prophylactic anti-cytokine therapy, though there are a number of different strategies being explored. So this would be patients getting tocilizumab or anakinra, before the onset of toxicity. Prophylactic dexamethasone has actually been studied prospectively as part of a cohort of the pivotal study that led to approval of axicabtagene ciloleucel, the product for large cell lymphoma. All patients in this cohort got dexamethasone 10 milligrams daily on the day of infusion, and then 2 days later, so 3 days total of dexamethasone. They saw no grade 3 CRS and relatively low rates of grade 3 ICANS. And importantly, doing this didn't appear to impact the activity against the lymphoma. The CR rates were still quite high. So this is now a fairly standard intervention for large cell lymphoma. And we give dex a lot with blinatumomab. It's given every time you start the infusion when you make dose adjustments. So we don't think that it has too much of an impact on the way that T cell directing therapy works. So could we apply this to Brexucel for ALL? Well, there's some challenges in just immediately applying that. So as I've mentioned before, the median time to onset of these toxicities is actually a little bit later with Brexucel and ALL than it is for axi-cell and large cell lymphoma. So because of the earlier onset with axi-cel, a 3-day course of steroids makes sense because the vast majority of the events are going to happen in those first few days. So it might be that to appropriately prevent these things from happening, you would need a longer course of dexamethasone, which of course means longer exposure to immunosuppressive corticosteroids. Could that actually impact the anti-leukemia activity of the T cells? We just don't know. So at this point, we at our center generally reserve this only for patients that we think are at really high risk. So people that have a really high disease burden or maybe some pre-existing medical conditions, we'll consider giving a few days of prophylactic dexamethasone. But until we have stronger data, it's not something we're doing on a regular basis. We are starting to get more data looking at long-term outcomes. These are some older studies now that were from before products were FDA approved. But you can see that really the only chance of long-term success is if you have a good early response. So the only long-term survivors are really those that were able to get into an MRD negative remission. Some factors associated with better event-free survival in these analyses, going into CAR T-cell therapy with a lower disease burden, having a higher platelet count, and then the inclusion of fludarabine, which is now a pretty standard part of lymphodepletion prior to CAR T-cell therapy for ALL, that does appear to be associated with a better long-term outcome. Now, as I've said, there's 2 products that are currently available for adults with ALL, but there is a third product that has gone through fairly extensive testing that may become available soon, and that's obicaptogene autoleucel or obe-cel. And data from this study were reported at ASH last year and meetings earlier as well. So this is a novel CD19 CAR T-cell product. It's not available or not been studied in other contexts yet. And the interesting thing about this is a couple things, really. So first, the binding domain of the CD19 CAR protein has a fast antigen off rate. So it binds to CD19, but then releases fairly quickly. And the hope is that this is a more physiologic signal to T cells that will hopefully reduce some of the safety concerns and improve CAR T cell persistence, less anergy and so forth. There's also a unique approach to cell dosing and delivery. So every patient is slated to get a flat dose of 410 million CAR T cells, but that dose is split between 2 different infusions based on the marrow blast burden that is assessed at the time of lymphodepletion. This study enrolled patients into 3 different cohorts based on their disease status at screening. So the traditional greater than 5% marrow blast was cohort A, but then they had a cohort specifically for patients that had MRD, and then a separate cohort for those that had isolated extramedullary disease. There were high rates of MRD response with this treatment. They treated 127 patients. 3/4 responded, and those that had morphologic disease, virtually all of them were MRD negative. The event-free survival with this product seems to correlate with disease burden. So you can see on the survival curve and then the median event-free survival on the table, basically the lower your disease burden, the better your outcome was. And perhaps most provocatively, there were relatively low rates of severe toxicity. So CRS rates of less than 10% in terms of severe manifestations, similar for ICANS. So relatively safe in terms of the toxicity profile. Now, when considering all these different options that I've gone through, inotuzumab, blinatumomab, CAR T cells, it can sometimes be hard to decide how to choose between these different options. This is a table that was in a review article I wrote with one of our former fellows that tries to highlight where I think, have evidence to support that these different agents are maybe a bit more favorable or a little less so. So this is what I sort of apply in my practice when thinking about how to use these different agents, where the data sort of supports them. So for example, with blinatumomab, we know lower disease burden appears to be associated with better outcomes. So that's generally what we'll use it for. But you have to make sure that it's logistically feasible for a particular patient. Those that have a higher disease burden, I'll generally favor inotuzumab so we can start it faster. But of course, we need to make sure they don't have risks of SOS. And because of the complexities of CAR T cells, the time it takes to get them, we need to make sure they have adequate control of their disease in order to navigate those different steps. and there's other characteristics as well. So the last few minutes, I'll just use this to go through some cases that highlight some of the sort of practical barriers to some of these different therapies and how we can try to overcome them using these different agents. So the first case is a young adult who experienced early relapse after a pediatric-inspired regimen. I was a 28-year-old man with Ph-negative B-cell ALL who I treated a few years ago, received a pediatric regimen, got into an MRD-negative remission. We did not recommend transplant up front because of the available data, but unfortunately had a difficult time staying on maintenance therapy. And about 9 months in, while on a trip somewhere, he went to the emergency room because he started to notice a lot of bruising. And they did a CBC, and he had a very high white count, low platelets, 93% circulating blast, so very high burden relapse. So he got admitted to a local hospital there that wanted to try to treat him, but he insisted on returning home here to Seattle. So he left the emergency room, got on a plane, flew home, came right to our hospital, and then was admitted. So he's now in our hospital with this high burden first relapse. So we're not likely to be able to control his disease long enough for him to get CAR T cells because of the time it takes just to produce them. Blinatumomab, we know, doesn't work very well in this setting because of the high disease burden. So that really leaves us with chemo versus inotuzumab. And we know that inotuzumab is better than chemo alone. But we do have to consider the cost of inotuzumab. Our hospital incurs a very high cost when we give this in the hospital. So we ended up giving him inotuzumab, and we plan to limit it to 2 cycles because that seems to reduce the risk of SOS. So we started inotuzumab in the hospital, but we transitioned him to clinic administration after the first dose. He was able to get into a morphologic remission with no detectable disease. We were able to find a matched donor for him, and then got him to transplant after a second cycle. He received myeloablative conditioning. 9 months later, he's still in remission. He had no SOS, no significant GVHD. So, unfortunately, relapses are often associated with high disease burden, making some of these products less appealing, which can then, and limiting the exposure of inotuzumab pre-transplant is an important way to reduce the risk of SOS. Maybe in the interest of time, I have a couple more cases, but I'll maybe just sort of skip those. If people have specific questions in mind, they can certainly ask it. So I'll just sort of come to my conclusion, comments, and future directions. So unfortunately, as you've heard, we haven't really talked at all about T-cell ALL because there's a number of barriers to developing immunotherapies for this treatment, but several groups are looking into it. There's a study of daratumumab that's ongoing in the US, but we don't really have any bispecific agents. And there are a number of other interventions like off-the-shelf allogeneic CAR T cells, better MRD studies, better predictors. So ultimately, CAR T cells have become a really important option in this disease. They have very high response rates and potential durable responses, but the toxicity profile needs to be considered, as does their availability. And hopefully, as we start to learn more about these products, we'll be able to integrate them better into the treatment landscape. So with that, I will stop and thank you very much.
Thank you so much, sir, for that wonderful talk. It was worth listening to you, sir. Thanks a lot for joining us today. And now I request all our discussants to please put the raise hand sign so that we can start our question answer session. Yes,
So,
Dr.
Amit, can I start, Dr. Sharath here?
Please go ahead, sir.
Yeah, thank you, Dr. Ryan, for that lovely talk. I was just querying this point, so once we have relapse disease, and as a strategy to get people MRD negative, if we use CAR T cell therapy, assuming that everything falls into place, is there a role to still then look at having to do a allo on the back of that? Because I saw some of the curves which you showed us. The Chinese data doesn't look very great, but some of the American data looks better. So
Yeah.
it's a thought for us whether we need to still back that up with an allo, or can we just sit and wait?
Yeah, we don't really know is the honest answer. The study that I think argues best for doing an allogeneic transplant after CAR T cells is the the so-called ROCA analysis that was reported at ASH last year. What's tricky about that is that included some patients that just got maintenance treatment, which was largely TKIs for Ph positive ALL. Because of the small numbers, they lumped all these patients together. They weren't really able to look specifically at the role of transplant. So it might be that it's really the maintenance approach that's the best that comes out of those curves. Honestly, in my practice, I think it is very difficult to frankly convince patients to go through it all. Even young, fit, motivated people, they go through CAR T cells. There's a lot of toxicity that can happen. And then to tell them, okay, now that we've got you through all this, now we've got to put you through an allogeneic transplant. A lot of folks just don't want to do it. So, I mean, I think if it's a patient that has Ph positive ALL that doesn't have a mutation that confers a high degree of resistance to like every TKI available or whatever, or they have some options for TKIs, I might favor that approach after CAR T cells and just cross your fingers. But if it's somebody with Ph negative disease that, you know, has already received prior therapies, I might try to recommend a transplant if they're willing to do it, and importantly, if they haven't already had one. For those that have already had a transplant and then relapse and then get CAR T cells, in that situation, I don't think you can justify doing a second transplant.
Right. Thank you.
You're welcome.
Thank you, sir. Dr. Sumit Mint, your question, please.
Am I audible and visible, sir?
Yes, please go ahead.
Thank you for the excellent talk. I would just like to ask a couple of questions. The first one is related to what Sharad sir already asked. So I have a young patient, 26-year-old male, Ph negative BLL, treated with pediatric inspired protocol, is persistently MRD positive, has already been counseled for a CD19 CAR T by another physician outside. And then he has come to me because he has a matched sibling donor and he wishes to undergo an allogeneic stem cell transplant with the matched sibling donor after the CAR T. So in patients who are in CR1 and who are persistently MRD positive, where do you place the role of allo transplant if they are going to undergo a CAR T?
Yeah, I would, I would say, even in that situation where it's tempting to think that a good response to CAR T cell therapy could lead to a relatively good long-term outcome, I would probably still recommend a stem cell transplant. If, again, all the various factors are in place and the patient is willing to do it and so forth. The data we have in adults for long-term follow-up after CAR T cells is really pretty limited. And as I showed, while it's fairly controversial, my sense is that the outcomes are probably better if you can get them through a transplant. Now, the point that I'll bring up, and again, obviously your situation is different than mine for any number of reasons, but in that case that you described, and I encounter this pretty frequently in my practice, that situation is really, I think, optimally suited for blinatumomab. So the BLAST study using blinatumomab for MRD, the outcomes really look quite good. Importantly, though, the good outcomes primarily come from getting blinatumomab and then going on to transplant. So if the plan is to take them to transplant regardless, I would contend that you may have better luck going with blinatumomab and then transplant. If you don't have blinatumomab available, or for whatever reason you can't give that, but you can give CAR T cells, I would then probably do the CAR T cells followed by transplant.
And if I may ask one more question, Dr. Amit.
Yes, please go ahead.
So a patient who's relapsed refractory BLL underwent a haplo transplant in CR2 at another center and had a relapse post haplo HSCT and has come to us for a CAR T cell therapy. Interestingly, this patient's donor chimerism is still 100%, and has got a relapse, which essentially means that all the T cells in his body are probably of the donor origin.
Right.
So, if such a patient, if you have take for CAR-T and you accrete the T cells and then you give it back, what is the risk of GVHD, considering the fact that A, he has 100% chimerism, and B, that he underwent a haplotransplant, which is a high risk for GVHD. So how do you deal
Yeah.
with these patients who undergo a CAR-T after a prior transplant?
Yeah, so fortunately, the risks of developing GVHD as a consequence of getting CAR T cells is pretty low. While it certainly is tempting to assume that it could happen just biologically for some of the reasons you alluded to, whether it's the effects of the lymphodepleting chemotherapy, whether it's alterations in the T cell biology by having the activation come from the CAR protein itself as opposed to, MHC T cell receptor, more traditional physiologic stimuli, there just doesn't seem to be a lot of GVHD that happens, even in the scenario that you described. So that being said, it's still important to keep an eye out for it, to monitor for it. Certainly, if you notice a patient develops, rash, nausea, diarrhea, et cetera, a few weeks after CAR T cell therapy, those are not common side effects of CAR T cells. So one would have to be pretty suspicious of GVHD and diagnose it and treat it accordingly. But fortunately, it doesn't appear to be a very common phenomenon.
Any other question, Dr. Sumit? Okay.
If I have time, I can ask one more.
Yeah, please go ahead.
So, at what is the dose of CAR-T cells which you give for adult ALL patients? And in case if you have something extra, do you cryopreserve it and use it, say, for an impending molecular relapse or flow MRD positive state, just like we use DLIs in allogeneic transplant?
Sure. I'll be honest, I can't remember the actual cell doses that are approved. I will tell you that generally speaking, as I recall, the manufacturer sends you the cell dose that is intended to be given. So you get the cells that are intended to be dosed, and that's what you give. There isn't a lot of manipulation on the side of the treating facility. So the scenario that you described of saving cells and so forth, that currently is not really a feasible strategy without manipulating the cell product in a way that could be a little bit risky. But the point ultimately of using a second infusion to try to rescue relapse and so forth, while that makes sense, unfortunately, when this has been looked at, which is, it's not a very common scenario, second infusions of CAR T cells, particularly the same product, don't appear to be very effective, at least, certainly in ALL. The reasons for that are not entirely clear. It doesn't appear to strictly be because of CD19. It may be something more complicated, like upregulation of immune checkpoint molecules that suppress the immune response or something. And that's a situation where, like, a patient was treated on a study. On the study, they got their cell dose, but there was some left over. They relapsed. The study allowed a second infusion, and unfortunately, the infusion didn't work. That's the situation that has been looked at a little bit. Could it work better for MRD relapse and stuff? I mean, maybe, but unfortunately, for the reasons I said, it's not really a practical strategy that you can use right now.
In your practice, would you use checkpoint inhibitors if you cannot give a second dose of CAR-T for those with some molecular relapses?
Generally not. We actually did a study of pembrolizumab for MRD and ALL. It doesn't really work. If you have literally no other option and you want to give it a try and you have access to it, you can. I just wouldn't be very confident in it working.
Thank you, Dr. Sumit. Dr. Kriti, your question, please.
Thank you. Hi, I'm Kriti. I'm a pediatric oncologist, so I'll kind of stick out in this crowd. But my question to you was, first of all, thank you for that brilliant talk. My question was, could you just talk to us about how effective is CAR T in controlling extramedullary disease and specifically CNS disease?
Yeah, so the most of the experience with CNS disease comes from like single center experiences using investigational CAR T cells or post hoc analyses or this ROCA analysis that I mentioned. So I'm pretty sure this was the case of the Eliana Tysogen-Laclusal study. It definitely was the case for the ZUMA-3 study. Patients with CNS disease were excluded from those trials. So we don't have, prospective data with these products in those contexts. But what I can tell you, and probably the best data comes from this ROCA collaborative. There was an abstract that was presented at the BMT tandem meetings this last year, where there was, 20 or 30 patients in that cohort that had detectable CNS disease. And I think the response rate was like 70% or something, so pretty high. Obviously, it's a retrospective analysis, a selected subgroup of patients. So I don't think the percentage exactly that was reported is so important. But I think the key thing is, yes, CAR T cell therapy can work for CNS positive ALL. There's similar data that supports using CAR T cells for lymphoma, secondary CNS lymphoma, and so forth. So we know these cells can work for CNS disease, and they don't appear to be associated with significantly higher risks of neurologic toxicity or things like that, at least the data that I've seen. So it absolutely is an option. How reliable it is, I think, is a bit of an artifact of some of the data we have. So,
can I just follow that up with something else as well? So I've had some secondhand experience with Kymriah and the data that you showed of ICANS. So we didn't see so much of ICANS in pediatrics when we use Kymriah. So is this the biology? Is this the product? Or what is essentially the difference?
Yeah, it's probably a difference in the product. So not to get into the weeds too much, but it probably hinges on the co-stimulatory domain of the CAR protein. So so Tisacel has a 4-1BB co-stimulatory domain, whereas Brexacel has a CD28 co-stimulatory domain. And the CAR T cell products that have CD28 do appear to have higher rates of toxicity, including neurologic toxicity. So obviously, could it be, really Tisacel for ALL in kids is by far the greatest experience in a prospective trial that we have of children getting CAR T cells. We have a lot of experience with CAR T cells in general, but it's mostly from older people with lymphoma and so forth. So it could be an age thing. It could just be, if you give Axi-cel to a 13-year-old with an aggressive lymphoma, they wouldn't be at risk of getting ICANS because they're young. So it might be an age thing, but there's definitely this distinction of the co-stimulatory domain that probably plays some role biologically in the difference.
Thank you.
Thank you, Dr. Kriti. Dr. Prakash Chitalkar, your question. You're muted, sir. Sir, you're muted, sir.
My question is about the extramedullary disease, Dr. Cassidy. I have only one quick question is whether in the context of the CAR T cell therapy, do you think extramedullary disease is a matter of volume of disease, or is it actually a different biology that the leukemia cells go and populate different organs? I mean, what does the CAR T cell biology teach you about extramedullary disease in leukemia?
Yeah, it's I don't know exactly what it is. There's probably a difference in the ability of the CAR T cells to sort of traffic and penetrate into big tumors, as opposed to the more free-floating leukemia in the blood and so forth. The marrow, of course, is its sort of own microenvironment. So I don't think it's strictly a disease burden issue. It's obviously like, it would be very hard to really quantify this, but if you think about the total amount of leukemia cells in a person's body who has, 90% marrow blasts and a white count of 50,000, that's probably a lot more total number of cancer cells than somebody that has, 3 or 4 masses that are 5-6 centimeters in diameter, right? So it's probably not a total disease burden issue. It's probably more of the sort of disease distribution and the cell's ability to get into all the different sort of spaces of a tumor. Could there be, immunosuppressing components of the extracellular matrix and other components of a tumor that don't exist in the blood and marrow? I'll be honest, those are a bit outside of my, area of expertise, but it's probably more than just the total number of cancer cells. Yeah.
Thank you. Thank you.
Yes.
Thank you, sir. Dr. Hamza Dalal, your question, please.
Yeah. Am I audible?
Yeah, you're audible.
Dr. Amit, am I audible?
Yes,
Yes.
you're audible.
Okay. Hi, Dr. Ryan. Yes. Thank you so much for that wonderful lecture. I actually had a practical question. So in India, although we have access to blinatumomab as well as CAR T-cell therapy, at least up to recently now, but the problem is that financially and economically, most patients are actually not eligible for them. So I wanted to ask you that for those patients who we do not consider for a transplant, say they are elderly or those who have already undergone a transplant in CR1, how would you treat with inotuzumab so that they achieve as long a remission as possible?
Yeah. Unfortunately, the long-term outcomes with inotuzumab by itself are not very good. So when I encounter this sort of situation in my practice, and it happens a lot because as the case that I showed, a lot of these patients have a high level of disease when they first are identified, which makes inotuzumab appealing. If you have all these options available, I think, using inotuzumab to get somebody's disease under better control, if they still have persistent MRD, because blinatumomab is available for treatment of MRD, at least in my country, and if it's available now in India as well, in this circumstance, you can use it per its approval for that MRD and maybe get a more durable response than you would get with, just a few more cycles of inotuzumab. You can sort of extrapolate that to a similar situation with CAR T-cell therapy. I didn't really talk about this specifically because it's a challenging topic without a lot of data. But inotuzumab is actually, the concept of bridging therapy. So the idea of giving people treatment to keep their disease under control while we're waiting for the T cells to be manufactured and so forth. There's actually been a fair amount of experience using inotuzumab specifically for that purpose. So like if you have CAR T cells, but you're not going to be able to give them soon, you could potentially use inotuzumab as that bridging therapy to try to get them to CAR T cells. So unfortunately, outside of that kind of situation, I don't use it a lot, but use just traditional maintenance therapy like POMP after a response to salvage therapy, particularly if they didn't get POMP in first remission. So if they got a transplant in first remission because of high-risk cytogenetics or whatever, and then they've relapsed, if they've never gotten maintenance therapy as an intervention, I will sometimes use it in that setting. Generally not after CAR T cells, generally after blinatumomab, but if it's inotuzumab, I've sometimes used POMP in that situation. I don't know that helps, and I have very careful discussions with patients that, we may all be doing this for nothing, but at really high risk of relapse, it's a fairly safe intervention and it's cheap. So we could try this if we want. And I have a low threshold to stop it if they're not tolerating it. So
after how many cycles of inotuzumab do you put them on maintenance? So after 2 or after 6?
So I usually when I use inotuzumab with the intent of taking them to transplant, it's 2 cycles. If there is no plan to go to transplant, I stop after 4. when we've looked at this, the rates of hepatotoxicity really start to go up even outside of a transplant for patients that get like 5 or 6 cycles. So, and I don't really know how much it helps beyond 4 anyway. So I usually limit it to 4 cycles of inotuzumab if I'm not taking it to transplant.
Okay, and just the last question. So if you have planned them for CAR T-cell therapy and you are using it as a bridge, and say the
Yeah.
patient does become MRD negative, do you still proceed with the CAR T?
Is there is there anybody from the FDA listening in? Yes, we've definitely done that. It's again, it's not the way that it was approved. It's not the way that was studied. But for the reasons I just said, since we know inotuzumab alone is not likely to cure somebody, in that scenario you just described, you know, the idea there is they've had a really nice response. You can't see their disease anymore, but it's still there. We just can't see it. So giving CAR T cells there, it's much like the reason we do allotransplants in MRD negative remission, right? We're doing it to prevent a relapse. Is that the optimal use of CAR T cells? Maybe, we don't know that. But for that individual patient, that may be the only time to give them CAR T cells, so we'll still do it.
Any
Thank you
question,
so
Dr.
much. Thank you.
Thank you so much. Dr. Balakrishnan Parthi, your question, please. You're muted, sir. Still you're muted, sir. Please unmute yourself. Yeah.
Yeah, looks like you're unmuted now.
Now, perfect. Can you please go ahead, sir? No, you are muted, sir. One second.
Something about your microphone, maybe. Yeah.
You can type your question. Please type your question. So, sir, there are some questions from the audience. Dr. Tribikram Panda wants to know what is the dose of CAR T cells to be infused in Zuma or Ileana study? What was the dose actually of CAR T cells infused in Zuma as well as Ileana too?
Yeah, you know, as I said before, I can't remember the exact dose. It's one of those things that, like, because the company just gives you the cells, it's not a number that's easy to remember, like, because you're not the one who's actually ordering it. It's on the, what I can tell you is, you know, within an order of magnitude, I believe it's, you know, like millions of cells per kilogram, like 3 times 10 to the 6 cells per kilogram. It's somewhere in that range. I think they're both products are comparable, if I remember correctly. Please don't hold me to that 3 times 10 to the 6 number, but it's something like that. There isn't a big difference in the total number of cells between the two products.
Thank you, sir.
And the thing is, like, these cells, you know, the dose I'm sure matters, but the important thing to remember is, like, when these cells go in, they profoundly reproduce and expand. So that's, you know, they will expand as the sort of stimulus in the body dictates, right? So even though you may infuse so ever many cells, there's probably hundreds or thousands of times more cells that are actually in there activated. So.
Thank you, sir. And any vaccination strategy post CAR T cell therapy?
Strategies post CAR T cell therapy?
Vaccination.
Oh, vaccination. Yeah. This is a rapidly evolving area that is hard to keep up with because, you know, our infectious disease doctors are also learning a lot about these things. So like what we do now is not the same as what we did 6 months ago, and probably won't be the same as what we do 6 months from now. But we don't subject people. Well, sorry. We will generally use an approach to vaccination similar to what we do for people who go through like an auto transplant, with the idea being that the degree of immunosuppression that these patients develop is probably comparable to that. So, for example, we certainly avoid respiratory viral vaccines for at least a few months, even if it's the right season to give them. But we'll maybe start, whether it's the seasonal influenza vaccine or COVID vaccine, about, I think it's 3 months after CAR T-cell therapy. But we generally recommend patients go through the full series of COVID vaccines again, not just get the one single seasonal one that seemingly we'll be doing now moving forward. And it's kind of similar for like hepatitis and tetanus and so forth, but those typically get delayed more like 6 to 12 months after CAR T-cell therapy. Similar for streptococcus and stuff. So I would suggest, talking to your local infectious disease doctors or going to various guideline sources to see, because this is evolving so quickly. What I say today may not be true in 3 months. So.
Thank you, sir. And any role of TK, tyrosine kinase inhibitors, as prophylaxis for CRS?
For CRS, not that we know of. There has been some work from some of my colleagues in Seattle that suggest, this is definitely not for ALL, but that patients with CLL who are on ibrutinib may actually, if you keep them on ibrutinib throughout their time, both from leukapheresis through cell infusion and thereafter, that being on ibrutinib may actually reduce the risk of CRS. To my knowledge, no one has attempted yet to extrapolate that to ALL or other diseases. There are some ongoing studies looking at it in other B-cell lymphomas and stuff, but we generally don't continue the ABL kinase inhibitors during that time. As I mentioned before, there may be a role to prevent relapse, but we generally don't start the TKIs until at least a few months after the CAR T cells.
Thank you, sir. Another similar question from Dr. Trivikram Panda about CAR T-cell efficacy in CNS relapse.
Yeah, as I mentioned before, there's a few studies out there. Probably the one that's the most applicable. There's one from pediatrics that was published in Lancet Hematology using Tisacel. It was published, I think, in 2020 or 2021. And then more recently with Brexacel, an abstract reported at the BMT tandem meetings this last year that shows indeed these cells can work. How reliable they are is a bit difficult to know because it's still a selected population, but they definitely can work in CNS.
Thank you, sir. Another question from Dr. Madhupriya. Is there any role in monitoring the number of circulating CAR T cells?
Yeah, at this point, no is the short answer. There's the tests that do this are, to my knowledge, not routinely commercially available. So that's a big practical limitation right there. You'd have to find a research lab that's willing to do it. But even if you did it, it's not clear what to do with that information. So for example, Brexacel, when this was looked at in ZUMA-3, virtually every patient loses detectable CAR T cells within about 6 months. But there are definitely people that can stay in remission beyond that. So it doesn't appear to be a very useful predictor of relapse with that product. It might be for Tisacel, but again, because it's not really a test that you can readily do outside of a research study, it's probably not a very practical tool, at least for now.
Thank you, sir. And any strategies to improve the length of remission following CAR T-cell therapy as of now?
Yeah, I think it's really for pH positive ALL, I would definitely, for somebody that got Brexacel, I would strongly favor putting someone on a TKI. Again, I'd probably wait at least 3-4 months before doing that. As I in the early days of CAR T cells, where we were nervous about doing something to inhibit or eliminate the CAR T cells, nobody got any treatment afterward. But since everybody loses Brexacel after 6 months, it probably doesn't matter so much. So I would generally use a TKI maybe about 3 or 4 months after for pH positive ALL. The really the more challenging question is the role of transplant, which, as we discussed before, is a pretty difficult one to convince patients to go through. If it's a young person who tolerated CAR T cells well, and you're really nervous about limited options afterward, and they haven't already had a transplant, I would definitely recommend a transplant in that setting.
Thank you, sir. Another question from Dr. Krishnanathan Kannan. How do you choose between allo stem cell transplant versus CAR T cell therapy after etching a CR in a relapsed state?
So I think because the CAR T cells are really only available in terms of, well, at least the way that things work in my country, you're only going to get it paid for by, insurance or the, third-party payers if somebody has at least some detectable disease going into it. My sort of attempt at humor earlier notwithstanding about a patient who becomes MRD negative with inotuzumab. So I think if your goal is to get somebody to a transplant, and they're MRD negative and they have a donor and they're in good shape, I would go to transplant. We know that can cure people. As I've said before with CAR T cell therapy, there's still a lot we're learning, how durable the responses are, the toxicities and so forth. There's still a lot we don't know. And we certainly don't have great experience using CAR T cells for patients that are already in a really deep remission in terms of what to expect. So if it's somebody who's in a really deep remission and they're ready to go to transplant, I would take them to transplant. I would reserve the CAR T cells for a relapse that might happen later. But if they have persistent disease, if they're in a morphologic remission but have MRD, and you can't get blinatumomab, or you still don't have a donor or something like that, if you know going in that their risk of relapse is going to be super high, particularly because of persistent disease somewhere, then I would definitely give CAR T cells and still try to get them to transplant after that.
Thank you, sir. That was fantastic. So the first choice always remains allo stem cell transplant, and alternatively, if there is no choice, then we can go for the CAR T cell therapy.
Yeah, exactly.
Thank you, sir. So I finished all the questions from the chat box. Any discussions you want to ask? Any other question? Fine. In that case, there are no more questions left. Fine, sir. That was a fantastic lecture. Wonderful lecture. Worth listening to you. And what a wonderful discussion. We heard you today. That was fantastic. Really, we got so much of knowledge regarding the CAR T cell therapy, and definitely will help us in the future practice also, sir. Thank you so much. And I now hand over to Mr. Prashant Agarwal for the final vote of thanks.
Thank you, Dr. Rayan. It was really wonderful presentation and the lecture. On the behalf of Adley Oncology, I would like to thank Dr. M.B. Agarwal, who considered us as a part of this webinar. At Adley Oncology, we are committed to pushing the boundaries of innovation. We are committed to provide the high quality oncology drugs at the affordable price. And we are sure that we would be able to make real difference in many people across the world. At the end of this webinar, I would like to say this: your support and your contributions are really instrumental in our journey towards shared visions. I would like to thank all of you for your time, your valuable insights, and making this webinar wonderful. Thank you. Thank you very much. We look forward to continuing this journey together. Thank you very much.
Thank you. Thanks a lot.
Thank you.
Bye.
Thank you.